And today we are honored to receive a very special education by one of our very special own. I will introduce him very well shortly. But today, I would, if today is your first time joining us, I would want to take just a minute to introduce us shortly. This is Ghana, Canada Medical Center once again. We are a specialist hospital and we specialize in not limited to, but in the following specialties, starting from general walk-in clinic where we see everyone that walks in. And then we have pediatrics, including neonatology. We also have a specialty in obstetrics and gynecology. We have urology as dialysis unit to take care of all your dialysis needs. Emergency care unit is always open to you as well. Ophthalmology and optometry, or the eye clinic, is active. Family planning, a surgical unit, ultrasound services, laboratory services. We also offer travel medicine. Our pharmacy service is always active. There's also internal medicine, where today we are focusing on especially our physician specialist, including cardiology. And then ENT, endocardiogram, and ECG. Most definitely, if for a very special reason you have to stay over with us, our canteen is also available to serve your dietary needs. Today, as part of our observation for our World Diabetes Day, our very special Dr. Alfred Lutterrodt, who is our internal medicine specialist for several years, over 3 decades of practice in Africa and also in North America, especially in Canada. He will be educating us on diabetes. Must you even care at all? Diabetes, must you even care at all? He's taking over in just a minute, but when he is done with your education, you will be allowed in to come in with your questions either by typing in the chat box section, or you will be allowed to unmute your device so you can ask by voice. So without wasting any more time, I would want to officially introduce you, Dr. Lutterrodt. Please, you may take over. Thank you very much.
Thank you very much also, Chairman. As you stated, today is recognized by the World Health Organization as Diabetes Day, and hence this webinar. I wish to thank and welcome all the participants this time. As stated, the topic is diabetes, must I care? And it's a loaded question. Diabetes, must I care? It will become apparent to you by the end of the lecture why you must care. You may ask the question, what is the importance of diabetes? It is a very common medical problem that is chronic and lifelong in those affected. It is associated with varied complications that can shorten life or affect the quality of life. It's an expensive disease to have because, as I said earlier, it's lifelong. Fortunately, diabetes is controllable to an extent such that the complications can be minimized, and therefore early death and poor quality of life can be greatly improved with good control. You may wonder how common is diabetes in Ghana. The prevalence from studies previously done reveal 3 to 4% of the population, particularly in the right age group, who have diabetes. So out of every 100, say over the age of 30, 35, definitely after 40, out of every 100 persons you meet on the street, 3 to 4 may have diabetes. I checked into the effect of gender on diabetes, and recent evidence would seem to suggest that in our part of the world, diabetes equally affects men and women. However, it's more prevalent in the urban areas and the city dwellers. It's estimated that outpatient management per patient per year can be as high as 3,000 cedis, which to some will be costly. In order to avoid the complications and the cost implications, there is the need for effective and efficient methods for preventing the disease in the first place. So at this point, I would like to answer the question, what is diabetes? It's a clinical situation in which blood sugars are abnormally high. Usually, the blood sugar of a healthy person is kept in a narrow range. If you eat, the sugar goes up, the body senses it and releases a hormone, insulin, that brings the sugar down. If you fast, and therefore your sugar is low, the release of insulin is turned off so that the blood sugar stays in a safe range. Today, we are talking about high blood sugar. And obviously, this will be due to lack of insulin or insufficient insulin, and or in some instances, there is enough insulin, but the receptor, or if you like, the keyhole in which insulin, the key will fit, the number of keyholes available for insulin to open the cells of the body for sugar to enter, the number is low. So it creates a situation of relative lack of insulin. Sugar stays around instead of going into the cells of the body. Diabetes doesn't occur alone. It tends to occur with other associated conditions that I'll describe in a moment. And together they conspire to bring about the severe heart, in particular complications. Clearly, diabetes is a lifestyle disease, and therefore prevention is directed at altering one's lifestyle if one is on the verge or has developed diabetes. In some instances, genetic or hereditary factors may play a role, but this is not very direct or very strong. The complications of diabetes can involve multiple important organs of the body. We have different types of diabetes. There's type 1 diabetes, which occurs in younger persons and is due to near total lack or absence of insulin. And hence the term insulin dependent. These patients cannot survive without being given insulin from outside the body or medically administered insulin. If they are not given this treatment, they won't survive. The second type, which is commoner, is non-insulin dependent type 2 diabetes. So relatively speaking, if you have type 2, you can get by without insulin as compared with type 1. This tends to occur in older age persons. Type 2 tends to occur in older age persons. Because of change in lifestyles in our part of the world, we are seeing younger persons having the type 2 type because they are obese or overweight. Occasionally, diabetes will manifest initially as a form of very serious complication that doctors call DKA, meaning diabetic ketoacidosis. Usually this occurs in the type 1 diabetic. Rarely or occasionally it don't occur in type 2 diabetic. Because of the lack of insulin, the body shifts to burning fat as a source of energy for the muscles and other organs in the body. Fat is burned instead of sugar. Sugar is the normal fuel that gives us energy to undertake the activities we do. So in diabetic ketoacidosis, because of insulin lack, the patient uses fat as the source of energy. And when fat is burned by the body, it produces a chemical which is an acid. So the whole blood of the patient or the whole body or the system of the patient becomes acidic, or I would call it acidosis. And very important structures and parts of the body cannot work in an environment of acidosis. So it's a serious manifestation, and it can kill within a few days if it's not properly handled. Who amongst participants or Ghanaians at large is likely to be affected by diabetes or suffer diabetes? Age is an important factor. We tend to see it from middle age or in the middle age group. So from about 30, 35, definitely after 40, it's more prevalent. As I mentioned a few minutes ago, gender is immaterial. Men and women are equally affected. Those who are obese are more likely to be affected or develop diabetes because obesity makes insulin insensitive or makes the body insensitive to insulin. As a matter of fact, such patients have too much insulin, trying to overcome the lack of response to the insulin that is around in the body. There are some medical conditions of hormonal nature, other than hormonal nature. They are relatively rare, but every now and then we see them as doctors. And they can precipitate diabetes. They can precipitate diabetes. They are commonly associated with diabetes. Then, more commonly, I'm sure some in the audience would know already that there is something called pregnancy-induced diabetes. In pregnancy, that pregnant state can induce diabetes. Again, what is at play in these patients is resistance to normal amounts of insulin, doing what it should do, pushing sugar or taking sugar out of the blood into the cells of the body. So there's pregnancy-induced diabetes. I'll talk a little more about that in a moment. So doctors call pregnancy-induced diabetes gestational diabetes. And it comes about, or the disease is caused by the fact that these patients, to begin with, have insulin resistance. In other words, they don't respond to insulin like a normal person would. And on top of that, during pregnancy, there are hormones released to maintain the pregnancy. Unfortunately, these hormones aggravate the inability for the body to handle sugar, and so hence pregnancy-induced diabetes. The risk factors of all pregnant women, not each one gets diabetes. Among pregnant women, those who are targeted or marked to develop diabetes include those who are obese, those who have a first degree relative with diabetes, those who have previously had pregnancy-induced diabetes must be aware that the second and the third time they are more likely to develop it. Another risk factor is the polycystic ovarian syndrome. Some women can't menstruate properly, and this is because there are cysts in the ovary, and it's invariably associated with obesity and maybe inability to handle sugar, which may develop into full-blown diabetes. Gestational diabetes tends to occur in persons who get pregnant at a later age, greater than 35. It's more likely to happen. It's more likely to occur when a woman is carrying multiple pregnancies. So if you have twins or triplets, you are more likely to develop pregnancy-induced diabetes. Now, once a woman has had pregnancy-induced diabetes, there's a high risk, 30 to 70%, for future development of full-blown diabetes after the delivery, so after the reproductive years. In such patients, 1 out of 2 would develop type 2 diabetes in a matter of within 5 to 10 years. Again, I'll stress the problem is failure to respond to insulin. Insulin is there to do its job, but the body doesn't respond to it. Pregnancy-induced diabetes can recur with future pregnancies to the tune of 30 to 80% of those affected. Patients who develop pregnancy-induced diabetes in later years in life may develop a combination of diseases which we call metabolic syndrome. So there's obesity, there is too much fat in the blood, there is diabetes, and this increases the person's risk for heart diseases. Therefore, a patient with pregnancy-induced diabetes is considered marked for future full-blown diabetes. And so after delivery, 6 to 12 weeks after delivery, they are screened with a glucose drink test to find out whether their body can handle a sugar load or not. And those who cannot handle the sugar load will be appropriately labeled as having pre-diabetes or full-blown diabetes and appropriately handled or treated. If the first screen, 6 to 12 weeks after delivery, is clear or is normal, thereafter it will be highly recommended if you experience pregnancy-induced diabetes to go for yearly checkup with a blood test that is called HbA1c. HbA1c is nothing but the red blood cells in the blood get coated with sugar if it's too high, if the blood sugar is too high. And the life of a blood cell is 3 months. So it gives an idea of how much or how high the blood sugar has been for the preceding 3 months before the test was done. So it's a very good test to use in determining whether somebody has been unknowingly walking around with high blood sugar. Hemoglobin A1c will be the test that you should request if you go for a checkup a year after pregnancy-induced diabetes. Of course, other appropriate tests, including the drink of sugar challenge test, may also be required. So how do we screen for diabetes? It's all to do with what is your blood sugar level. A normal person after overnight fast, the blood sugar should be less than 5.6 in the units that we measure blood sugar in Ghana. And the hemoglobin A1c should be less than 5.5%. This is considered as normal. From normal, you move to you are at risk for diabetes. And in this group of persons, the fasting sugar is between 5.6 to 6 millimoles per liter. And the hemoglobin A1c is between 5.5 to 5.9%. From there, you're getting closer or inching closer to full-blown diabetes. And the next stage is called pre-diabetes, where the fasting sugar is between 6.1 and 6.9, and hemoglobin A1c is 6 to 6.4%. If you exceed these parameters, i.e., fasting sugar more than 7, hemoglobin A1c greater than 6.5%, you are considered to have developed full-blown diabetes. So this is how the suspicion is confirmed by laboratory tests. Can diabetes be prevented to a fair extent? The answer is yes. So beyond 40, if you go for regular checkups, I'm sure most physicians are competent enough to know that diabetes is common and therefore your blood sugar should be checked. In case it's not done or overlooked for whatever reason, it's up to you to take ownership of your health and request to know what your status is with respect to fasting blood sugar. So through regular checkups, we have at least 2 steps before you develop full-blown diabetes. You could be found at risk sooner than you develop full-blown diabetes. And in the earlier stages, if appropriate steps are taken, you'll be held back and prevented from developing full-blown diabetes. And in this regard, non-drug means are used to prevent progression. And this will be by means of diet, by increased physical activity. When you increase your physical activity, sugar is used by the muscles, is broken down and doesn't stay in the blood. By ensuring that you have an ideal weight, the little insulin that you have will be able to work more efficiently. So weight loss or weight control are some of the means that we can use to prevent development from pre-diabetes to full-blown diabetes. These days, we, or very occasionally, there's an old diabetes pill called metformin, and another one called Actus that may have the property of preventing a pre-diabetic from developing full-blown diabetes. More recently, there is a weight-losing drug which is also used for controlling diabetes called Ozempic. And Ozempic and its related drugs, or family of drugs, may sometimes be used at a pre-diabetes level to prevent the patient from developing full-blown diabetes. Of course, if the drug makes you lose weight, then the little insulin that you have becomes enough. And that's how it works in preventing full-blown diabetes. Apart from the laboratory test, how else will a doctor diagnose the patient as having diabetes? And we use traditional methods, which include taking a good history from you, the patient. And in the history, there are symptoms, classic symptoms that give away the game that you have developed or you are developing diabetes. Then this can be confirmed with blood tests. So a patient may go to a doctor with symptoms, and then the doctor will say, the combination of symptoms suggests diabetes. Do tests, confirm it, and get on with treatment. Sometimes it's found by accident, going for unrelated problem, or you're going to have surgery, you're going to have your gallbladder out. You need to be checked before the surgery to make sure you are well. Blood tests are done, including blood sugar usually. And without you knowing, the report comes back, oh, it's high. Then the 3-month average blood sugar test is done, and that's high. So then it becomes apparent that the patient has had diabetes without knowing that he or she had diabetes. It's been found incidentally. Of course, the patient will be appropriately labeled and given the appropriate treatment. So that's part of the clinical assessment. The history is what I've mentioned. Sometimes when you go to a doctor, you may have complications of diabetes. Your feet are swollen, or you are short of breath, your blood pressure is high, and then questions are asked, and we'll find out, hey, your kidney is failing. Yeah, it's a complication of diabetes. Then we'll start digging and looking around more, and then lo and behold, we'll find out, hey, your sugar has been high, and not just now or at the moment, but it's been high for the last 3 months. So sometimes patients go to the doctor with a complication, and then we discover that that complication is being caused by diabetes that the patient wasn't aware of. Okay. Sometimes diabetes is diagnosed because the patient goes to the doctor with some of the associated conditions. So if I see a middle-aged patient who has hypertension, I won't let go until I check the blood sugar, because I know blood pressure and diabetes go hand in hand. If the patient comes to me with a stroke and you check and the cholesterol is high, I'll suspect or question myself, does the patient also have diabetes? Because they go hand in hand. So sometimes associated conditions will make one wonder and look for diabetes, and the patient may be proven to have the condition. After the doctor talks to you, you will be examined from head to toe, and we're looking for particularly your blood pressure, your BMI, which is your weight relative to your height, abdominal fat is a giveaway that a person may or is prone to develop diabetes. So we measure the abdominal girth also. And then, of course, the rest of the body is checked. Heart, lungs, abdomen. In fact, even the eye, the back of the eyes should be checked for evidence of damage to the back of the eye by the diabetes. That may be a giveaway. Yeah. Now, once the clinical assessment is done, then, of course, blood tests, classically the blood sugar, and then the 3-month average hemoglobin A1C. Yeah. Of course, if you have diabetes, you will spill sugar into the urine, and that's the simplest, easiest way to find out. There'll be sugar in the urine. So when you see the doctor, you'll be questioning about these symptoms. These are some of the common symptoms. You should be aware if you have them or know someone who has them, raise the question or the prospect that the person, you may be having diabetes. Excessive thirst and excessive passage of urine, getting up too many times during the night to pass urine. And invariably, these patients, when they pass urine, it's like a tap has been opened, because the sugar drags water out of the body and the patient makes large volumes of urine. So thirst and excessive urination. Diabetes can be the reason why someone is losing weight. So anyone with weight loss, I think most doctors will check for diabetes without you mentioning it. When the sugar is high, it affects the lens in your eye such that you can't see far. You cannot see far. So some patients, a change in vision for some may indicate that the person is walking around with a high blood sugar, which makes the lens swell such that you can't see far, but you can see near. Another symptom that a patient presents with is frequent infections and usual infections of the skin, boils. In the female group, recurrent yeast infection of the genitals could be a clue or that a sign that you may be developing diabetes. Apart from the blood sugar, other tests are necessary to find out whether the diabetes has done damage to other important organs, including the kidney. So through a simple blood test, we can tell whether whether one's kidney is functioning well, even though they have diabetes. From a urine test for protein, the suspicion can be aroused if there's too much protein in the urine. So you definitely, if you've been found to have a high sugar, you will have a kidney function test. It's a blood test. The person will have his serum cholesterol checked, because high cholesterol keeps the company of diabetes. And the two together, dynamite, causes strokes and heart attacks and other heart diseases. A doctor will want an ECG done to check out if you have high blood pressure, whether the high blood pressure is and made the heart bigger, or if you've quietly had a heart attack, diabetics can have a heart attack without knowing by way of symptoms, the classic symptoms. So an ECG may reveal that such an event may have occurred quietly some time ago. Ultrasound of the heart will be done to assess how well the heart is pumping. With diabetes, particularly if the person is hypertensive, the heart muscle gets very thick, and that can be seen on the echo or ultrasound of the heart. Blood pressure keeps company with diabetes. They go together most of the time. So your doctor may ask you to go for a test in which a device is applied to your arm and left in place for 24 hours. And this device will check your blood pressure every half hour during the day and every hour during the night. The evidence gathered is for sure the best way of determining whether your diabetes is associated with high blood pressure or not. And this may be necessary because some patients, when they visit the doctor, their blood pressure goes up because they are nervous. We want to separate such patients from those who truly have high blood pressure, and this walking blood pressure test is the way to go. Another way of finding out if your diabetes is associated with high blood pressure is for you to check your blood pressure at home if you have a machine. Then you can check the readings at home, which we know to be better than the readings in the doctor's office. Home blood pressure readings predict future heart and heart-related events better than the blood pressure that a doctor gets in his office. So a diabetic, I think, will be encouraged, if he can afford it, to get a blood pressure machine and monitor his or her own blood pressure at home. Of course, in conjunction with what the doctor is measuring or obtaining in his or her office. So by this stage, we've proven that you have diabetes. We've checked for complications, and we are set to begin management or treatment. And here I would like to emphasize that in light of the chronic nature of diabetes, it is very, very important that the patient takes ownership of the management. I, the doctor or the nurse or the dietitian, we are just there to help and provide information. But you, the patient, owns the disease. You live with it every day at your home. We are not at home with you. So it's very important that you listen to advice and take care of yourself. This aspect alone cannot be replaced by the best medicine in the world for diabetes. Very, very important that the diabetic patient has an insight into his disease, possible complications, how to look for them, and how to take care of himself or herself. Of course, information will be provided by a supportive team, usually not only typically in the best of places, the care is provided by a team of doctors, a team composing of a doctor, a nurse, a dietitian, and the doctor can be. There are many doctors. They can be the primary doctor. They can be the heart specialist. You may end up seeing a kidney specialist. All right. So all who are there to help, the dietitian is there to help. So once the diagnosis has been made, you interact with all these medical and paramedical staff. On the whole, the aim should be optimal treatment to control the blood sugar, but all patients are not the same. Some work night shifts, and so what works for them may not work for someone who works during the day. So a lot of factors will be taken into consideration to design what is appropriate for each patient in order to ensure optimal control. Dietary management of diabetes is very important, it's cornerstone. The objective of that is to reduce the amount of sugar or sugary food or calories that the diabetic patient eats daily. The patient is advised to stay away from starches or keep to the minimum starches that have high glycemic index. We prefer starches that have low glycemic index. What this means is that yam, kenkey, bread, rice, these are all starches. They raise the blood sugar. But the speed with which, after eating any of these, the sugar rises is different for each one. We prefer that you eat the starches that increase the blood sugar gradually, not suddenly. And I'll give you examples in a moment. We prefer that, or it's ideal that, a diabetic patient is consistent and has frequent small meals rather than, oh, I'm waiting till in the evening, then you have one big meal. That doesn't work well for a diabetic. And the practical example I'll give you is as follows. Assuming you have a rack of, or shelf with many books in it on the shelf. You want to move the shelf of books from one room to the other room. You can do it in one of two ways. If you are strong, you lift the whole shelf to the other room. That's the person who has normal blood sugar. Insulin is working very well. If you are not strong, what do? You take a few books at a number of times to the other room, and at the end of it, you've moved all the books. So your food has to be divided into, if you're diabetic, into small bits, because the body can't handle a large challenge of starch or sugar. So that's why people give us impatient, you give all kinds of excuses. No matter what, it's better to divide your food into bits and have little bits throughout the day than one or two big meals. Eating animal fat should be trimmed off meat in particular, because that adds to the cholesterol problem. Vegetables are recommended. They are filling, and yet they contain less calories. Diabetics should avoid the craze in town for fast food. It's better if a diabetic starts from scratch and prepares his or her own food. And weight control, paying attention to the weight in the diabetic is very, very important, and aiming to or towards what is ideal. If you ask based on your height, you will be told what your ideal weight should be. And if you're a diabetic, you should make every effort to work towards that. So these are all non-drug methods of controlling, and is equally, if not more important than me giving you pills to take to control your blood sugar. So on this slide, I show different foods and how well or how rapidly they increase the blood sugar after you've eaten that type of food. The glycemic index is measured by a score. If it's less than 55, that's good for the diabetic. Medium is 56 to 69, and high is anything over 70. So if it comes to bread, for example, hey, brown bread is preferable because its glycemic index is lower. If it comes to rice, jasmine rice is preferable to white rice. If it comes to corn-based meal, common in Ghana, it appears kenke is better than banku. It comes to fufu, compared with boiled yam, I think boiled yam is better than fufu, as you can see there. Sweet potato is better than plantain. Cowpeas is much better than Tom Brown. And we like fruits. Pawpaw is better than watermelon by far. So if a diabetic wants to have a fruit, pawpaw will be preferable to watermelon. And a diabetic should avoid drinking canned soft or bottled soft drinks like Coca-Cola because the glycemic index is outrageous. So if you drink a bottle of Coke, your sugar will rise very quickly, and you are a patient in who cannot handle quick rise in blood sugar. So the sugar will rise quickly and stay high for a longer period compared with a non-diabetic. I've mentioned that diabetes and hypertension are bedfellows. They are found together. High blood pressure is twice commoner in diabetics than non-diabetics. And 50 to 70% of diabetics will have high blood pressure depending on the age. The older the patient, the more likely. And both conditions are common in Ghana. Hypertension coupled with diabetes speeds up complications pertaining to the kidney. In other words, you are more likely to get kidney failure if you have both conditions and they are not controlled. You are more likely to have hardening or stiff arteries. The arteries are the pipes from the heart that deliver oxygen-rich blood to every corner, every aspect, to the toe tips even, yeah. And when the arteries are stiff, the heart has difficulty pumping the blood to the extremities. And in fact, the heart has to work harder. That's how come the blood pressure goes up. So if you have high blood pressure and diabetes, this process of stiffening occurs to a greater extent, perhaps at earlier age. And that's why both conditions should be properly controlled. High blood pressure with diabetes increases the risk for heart attacks, for heart failure, and then strokes. Okay. Diabetes with high blood pressure can lead to damage of the back of the eye with consequent blindness. In fact, diabetes is a common cause of blindness, or one of the leading causes of blindness. So, and again, high blood pressure has something to do with that. So if you have both conditions, we pay attention to both, ensure that both are very well controlled. How do we control the blood sugar? The patient who has diabetes lacks insulin, and therefore treatment is replacement with insulin or supplement with insulin. And insulin, there are different types of insulin. Some act very rapidly and it's all done in 6 hours, 8 hours. Some act more slowly over maybe 18 hours, 24 hours. And depending on your situation, you could be prescribed a quick-acting and a slow-acting insulin. Sometimes they come already mixed. So you take from one vial, you take the insulin and you get both a quick-acting one, which will go into action. Immediately you inject, and then a slow-acting component will take over hours later. In fact, so much progress has been made that these days there are machines that can measure your blood sugar and then at the same time inject you with insulin. We haven't reached there yet in Ghana, but this is available. It's expensive. So it's acting like the pancreas in the body, which senses how much sugar there is in the blood and then turns on or releases insulin or turns off or stops releasing insulin. So this development, this is available, is being used elsewhere in the world. Insulin particularly is needed for the younger diabetics who have type 1 or insulin-dependent diabetes. Now, if you have type 2 diabetes, which is the commoner type, then we use pills or tablets taken by mouth to control the blood sugar. They act by squeezing insulin out of the pancreas or making the body more responsive, more sensitive to insulin. And there are different kinds, which for this lecture, for this webinar, I don't think we need to go into. But one of the oldest is metformin. Yeah. Okay. Fortunately for us, in the last 10 years or thereabouts, there are newer diabetic tablets that can be taken by mouth. That these newer medications do not only lower blood sugar, there's increasing evidence that they help minimize and or prevent some of the complications of diabetes, particularly with respect to kidney failure, to heart failure, these two in particular. And therefore, the only problem is they are more expensive, much more expensive. So if you can afford it, it's your prerogative or your right to ask your physician to consider using one or more of the newer agents or drugs, so that while your blood sugar is lowered, the medicine at the same time minimizes the odds or the chance of suffering that complication. Now, when you try to control your blood sugar by insulin or by these tablets, there's a risk of the blood sugar going too low. So every diabetic should know what are the signs and symptoms of the blood sugar being low, because it can be fatal if ignored. It can lead to convulsions. It can lead to unconsciousness. Usually, there are early warning signs which, if the diabetic is aware of, will know. And then the treatment is very easy. Get something sweet to eat or drink, and the blood sugar will come up, and it's going to be like night and day. And of course, if this happens, then you should let your doctor know, because it calls for adjustment of the dosage of insulin or the tablets that you are taking. Is it worth your while if you're a diabetic to take these medications, insulin and the tablets? And my answer is, you better believe it is very worthwhile. With treatment, there's ample evidence to show that complications are minimized and or delayed, and life expectancy is longer and the quality of life is better. Therefore, you should pay attention to your doctor and follow instructions with respect to drug treatment. At the same time, while lifestyle adjustments are ongoing. Sometimes a diabetic may suffer acute or sudden complication. As I said earlier on, it's a chronic disease, but every now and then we see a patient in acute crisis because, for example, if the blood sugar is too high, the patient can pass so much urine that the patient will become dehydrated. If you become dehydrated, the kidneys will stop working. You become weak, your blood pressure is low, you can't stand. So this is one reason why the sugar should be kept controlled. I mentioned burning fat instead of burning sugar, which is called DKA. It's a serious complication that has high mortality, kills if it's not properly handled. Diabetics can get infections. If you're a diabetic and you know your body and you don't feel right, it could be an infection in the making. And the common areas of infection, kidney and bladder infection. And the danger with diabetics is that the infection, which started locally, can spread into the blood. Blood goes everywhere, and it means the whole body is infected. And that can be lethal, right? It can kill. So anytime a diabetic doesn't feel well for whatever reason, get checked. Go see the doctor immediately, because it could be the beginning of a serious infection. Some diabetics complain of tiredness and weakness. Again, if you have these symptoms, you should get to see a doctor if you know yourself to be a diabetic. And the long-term complications are for kidney failure, and then hardening or stiffening of the blood vessels. I've mentioned the consequences: heart attack, stroke. You may lose a toe, a foot, or a leg because of diabetes. The pipes are stiff and narrow. Oxygen-rich blood is not delivered to the extremities. And so the oxygen lack causes death, local death, or gangrene of the extremity that may call for amputation. And so a diabetic has to take very good care of the feet, toenails, trimming the toenails, and that kind of thing has to be done carefully by someone who can, let's say, if you can go to a foot doctor or someone who trims toenails, I think you are better off, especially if you can't see very well. In addition, diabetes deadens or numbs the nerves at the tips of your fingers and toes that make you feel. So if you are trimming your own toenail, you may cut yourself without feeling the pain. So foot care is very, very important. You should check to make sure that there are no cuts or bruises on your feet if you have diabetes. In men, it can cause impotence. It can cause blindness. I mentioned that already. High blood pressure coexists with diabetes. And the nerve damage, burning feet. Some patients complain of burning feet. In its severest form, your feel of hot and cold may not be up to par. In the severest form, it can affect the digestive system such that you can have diarrhea in its severest form when the nerves are damaged. And blood pressure control becomes affected. So the patient becomes lightheaded when he or she stands up. Okay, this slide, I think we've spoken about this. The associated medical disorders have spoken about high blood pressure, cholesterol issues. We have to pay attention and check for long-term complications. What is new in the management of diabetic? I told you about the machine that monitors the blood sugar continuously and has a mind of its own and says, oh, this sugar is too high, and then shoots insulin into the blood to bring the sugar down. And that's the latest development. It hasn't reached here yet. If you can afford it, then outside the country, one can obtain such a machine. You should, it's your right to ask for the newer diabetic tablets if you can afford it, because they are more expensive. And then go for checkups to be screened for complications. Weight control, very, very important, very, very important. And your treatment plan should be individualized. What may apply to patient A may not necessarily apply to patient B, simply because maybe B works at night and A works during the daytime. Yeah, so you have to let your doctor know your special circumstances so that the treatment is planned around that. I believe this is the last slide. So I'll end here exactly 1 hour and answer any questions that you may have.
Okay, thank you very much, Dr. Lutterrodt,
Yes.
for this wonderful education. It's time for questions and answers. So, ladies and gentlemen, you are allowed to type in our chat box to ask your questions. Dr. Lutterrodt will spend a few more minutes and answer all your questions as much as he can. You are also allowed to unmute so that you can speak into your device and then you ask me. But just before the first person asks his or her question, once again, this is Ghana Canada Medical Center, and we are coming your way live from Accra, East Legon, Adjiringanor. Today's education by our internal specialist, Dr. Alfred Lutterrodt, was on diabetes must I care. So if you came late, we are basically learning about diabetes. So you can equally ask your question. So question time. We are spending just a few minutes in this session. Please type your questions or you can unmute and ask your question.
Hello, Doc.
Yes.
Good evening, and thank you for the education. I want to understand something. I'm diabetic, and during the day, my sugar is very stable. So sometimes if you take the medication early in the day, I see myself, my sugar really going down. But then in the night, during the night, I did testing, 2-hourly testing, and for some time, and I realized that my sugar starts coming up from 2 a.m. So if by 2 a.m. I'm around, let's say 5.4, by the time we get to about 6 o'clock, I'm hitting about 8. So I've been wondering why this is so.
Very good question. 8, when you rise up in the morning before you have anything to eat, if it's 8, that's good control as far as I'm concerned. The increase that you see from 2 a.m., you are very right. The body is wonderful in the sense that there is a rhythm. The body has a rhythm, like the the moon going around the earth. Our own bodies have a rhythm, and the rhythm is set such that from about the time you mentioned, as you are getting ready to wake up, certain hormones we know in the body that increase blood sugar start to increase. 3 a.m., 4 a.m., thereabouts, you said 2. the blood sugar, those hormones increase, and that's why the blood sugar increases. And it's interesting in the sense that we know that most events, such as heart attacks and stroke, occur in those hours that you describe, early morning. That's when, the blood becomes stickier, so to clot and block an artery, and you get a heart attack or you get a stroke. And so what you are describing is recognized, it's explainable, but I can reassure you that the levels that you mentioned, 8, fasting sugar of 8, if half my patients have that, I'll be rejoicing and dancing. Yeah. So no, I wouldn't worry about that. Yeah.
So it's not alarming. It shouldn't be something that I should be concerned about.
No, it's a normal phenomenon.
Okay.
It's a normal phenomenon. It's recognized in medicine.
Okay.
Yeah. There's the early morning surge, we call it. Surge.
Okay.
Yes.
All right. Thank you, Doc.
Yes. Yeah.
Okay, Victoria Gifty, thank you very much for your involvement. In the chat box session, there is Dr. Lucho. Somebody wants to know by name Bernard Kofi Boateng. He wants to know what is the best way to lose belly fat, more fasting hours or exercise?
Well, that's a tough one. Yeah. Obviously, exercise will help. The newer drugs like Ozempic, I believe, target abdominal fat also. They are more expensive. They are newer, and they are taken by injection. Though oral or tablet forms are going to be available in the foreseeable future. Metformin supposedly helps in this regard, especially if you have type 2 diabetes. But other than Ozempic and then the metformin, I'm not aware of, and then any other drug, of course, plus lifestyle, like you said, physical activity, would be the way to control belly fat. Actually, and the fat, when you talk of belly fat, it's not the exterior, it's what is inside. You have a veil inside under the one. If you open the abdomen, you see a veil-like tissue, and that's where the fat is. But the newer treatment, particularly Ozempic-like drugs, and metformin will be what I would recommend. And in addition to, of course, amount of calories, the amount of food that you eat in a day must be cut down. In addition, plus the physical activity. But that is that's a tough one. That's a tough one to. I'm sure that's why you're asking.
Okay. In the chat box as well, Frederica wanted to know, or she wanted you to share with us some of the names of the new drugs, so she'll be able to differentiate them from the old ones.
Yeah, the new one is called Forxiga, and Jardiance. Those two are cousins. I think Forxiga came before Jardiance.
Okay. Thank you very much.
And then Ozempic is a new one. Yeah.
Okay.
Those are the two.
One, Madam Letitia also wanted to know, what does it mean to be pre-diabetic?
Pre-diabetic, it means that based on your testing, your numbers fall within a certain parameter, And when you are in that parameter, it means you are at the doorstep of diabetes. One more step, and then you go into the diabetic range, what we consider as full-blown diabetes. So that's all it means. Yeah, it's numbers. We use certain numbers in terms of the blood sugar, and then the 3-month average hemoglobin A1C. And if you fall within a certain range, the label pre-diabetes is attached. Pre means before diabetes. That's what pre means. So you're on the doorstep, about to become, but it can be rolled back. You can, if you take the proper measures or steps, we can prevent you from going into the diabetic range. You can fall back into the normal range just by losing maybe about 10% of weight. I've seen it happen. Yeah, right.
Okay, thank you
so
very
weight
much.
loss is very important. Yes, yeah.
So far, no more questions, and I would not want to judge too quickly. For just a couple of minutes, 2 more minutes, so that we can close by 8:15. If anybody else has an additional question, please, you may go ahead.
Right. Hello?
Yes, I'm listening.
Yes, I'm David.
Yes, David.
Yes, I'm speaking now from Takrady. I joined, but I had a link in the latter time, so I think about you were over 30 minutes before I joined. In fact, your lecture was so interesting, and I do read a lot about this diabetes and hypertension, which I am a patient of. I use the drugs of metformin and how do you call it? Amlodipine. Amlodipine, the control and manages. Yes, you mentioned about the food, the type of food and this we eat, and then the pawpaw being good. If I myself, I like pawpaw very well, so I think yes, it is on my way and it's good. Yes, but I do have regular toe bend. My toes normally I get bent. Yeah, bends in my
Bends,
toes.
yeah, yes,
Yeah,
yeah.
toe bends, and I wake up, and it occurs so much in the mornings when I wake up from bed.
Yes, yeah.
Yes, and I have the machine for also checking this hypertension thing. Yes, like the measurement you get the figure of 8. I do record more or less 8 in that in the mornings, which you claim now is good, which I have about 60 years. So these bends that I have in the two, which are so regular, how best do I work on it? Regular these days, I do have heartburn after eating all those digestive system. Yes. So any clue to that?
The burning in the feet or
The toes,
irritation.
particularly the toes.
Yeah. Okay.
Yes.
So like I said, the diabetes for a long time will damage the nerves and give rise to this feeling or sensation or symptom. The only thing that we can do about it, if it's unbearable, there is a drug called pregabalin. There's a drug that one can use. I can't promise you night and day. In other words, if 100 patients take it, how many of them will come back to me and say it worked? In some, it will work. In others, it wouldn't work. But that's worth trying. It's called pregabalin. That's what it's meant for. Yeah. For the burning feet. Yeah.
Is it PRE?
Yeah, GABA.
GABA.
LIN.
Pregabalin.
Yeah,
okay.
Yeah.
And is it in the pharmacies that I can get direct prescription? I can walk in and buy?
I think it's usually by prescription. Usually, though, I won't be surprised if a pharmacist gives it to you without having a prescription. Ideally, it should be. It's a prescribed medication. It's not over-the-counter medication. So
So I
you either
can
get a
go.
doctor, your
I can
regular
go to
doctor.
my doctor and tell my doctor that I've received these lectures from you, so you should prescribe that for me.
Well, you've heard of this, You Google it and you read about it. But you'll find
yeah, it's
information.
about how to purchase it and use.
Yes, it will be there. It will be there, yeah. But that's the only thing I know we use. Short of taking good care of the diabetes, what else? There's nothing else that's why we don't want you to get into that stage. Earlier on. How long have you had the diabetes?
This was detected in about 2017, so we can talk about
Almost
8
10
years
years
now.
coming.
Yes, 8 years, yes. Okay, but Doc or Prof, how do we get access to you? As speakers as well, if you want to have conversations like this for education and direction.
You are in Takoradi, you said?
Yes, please.
Let me see. I can give you my number.
Okay.
If you have a question, I wouldn't mind. You can call me. I'll do the best I can to answer.
Yes, please. Yes, please.
My number is 020
020, Queen, right? 020
67 60 67
67 020 67
6760
60
725.
725. Prof, I'm very grateful.
Okay.
Please, your location is in Accra.
No, can you repeat the number again, please?
You repeat what you have for me. What you wrote down.
Someone is asking that it's on me. I know it's 020 60.
No, 67.
67, sorry. 60.
Yeah.
725.
Yes, that's it. Yeah.
Yes, 020 67 60 725.
725, yeah.
Oh, okay, sir. And sir, are you in Accra?
Yes, I'm in Accra.
Oh, please do us good to visit Saturday. Electricity.
Okay.
Sir, so grateful, sir. So grateful.
All right, thank you. Yeah, it's my pleasure. Yeah.
Yes, sir.
Yeah.
Okay, so ladies and gentlemen, once again, thank you very much for joining. All too soon, we have to bring today's lecture and wonderful education to an end. But when you go to our chat box, there are very important information you would want to have. There is a link that would bring you straight to our WhatsApp platform page that you can further engage us. This is Ghana Canada Medical Center. And our team consists of highly trained physicians, nurses, and healthcare assistants that are always on hand to give you the best care. We also have expert Ghanaian and non-Ghanaian practitioners from all over the world practicing at our center. Our services are not just limited to Dr. Lutterrodt's great internal medicine specialty, but we also have eye clinic. We have the pediatrics and neonatology. There is a well-furnished laboratory, obstetrics and gynecology. There's special attention Dr. Lutterrodt pays to diabetics. We also have an ENT clinic. There's general surgery, midwifery, and postnatal care. We do immunization. There's ophthalmology. We have a very good functional pharmacy. There's also dialysis service, urology, and canteen. If you happen to belong to any of these various insurances, yes, please be bold to walk to our front doorstep. If you are with Acacia Health Insurance, Ace Medical Insurance, Apex Health Insurance, the Cosmopolitan Equity Insurance, GAB, that's the Ghana Association of Bankers Health Insurance, Glyco Health Insurance, Metropolitan Health Insurance, Nationwide, Phoenix Health Insurance, Premier Health Insurance, we will be glad to work with you. There are various corporates who also work with, but most importantly, we also have a contact I'm mentioning to everyone in case you are listening. You can pick it. and call our front desk. If there's any further information you want to know, we'll be glad to share with you. So our official number, you can reach us 24/7. It's 055 199 0807. Our official line that you can reach us 24/7, 055 199 0807. So once again, thank you very much for joining today's lecture. If you want to contact Dr. Lutterrodt only for your health needs, definitely reach out to him also on 020 725. He is in a clinic from Mondays, Tuesdays. There is no Wednesday, but on Thursdays and Fridays as well. You can catch him 8:30 a.m. in the morning to 11:30 a.m. I repeat, Dr. Lutterrodt's clinic hours and days are on Monday, Tuesday, Thursday, and Friday, 8:30 to 11:30 a.m. in the mornings. So, once again, thank you very much for joining us today. We would love to have you another time on our next lecture. Thank you all. There is a link you can click on to take you to our various social media platforms. We are on TikTok, we are on Facebook, we are on Instagram, and also on YouTube. The fastest way to find us is in this chat box. But when you Google our name online, Ghana Canada Medical Center, it will take you straight to our website or any of our social media platforms. Dr. Lutterrodt, thank you very much for such an educative lecture. And for all ladies and gentlemen who join us today, thank you very much. This is where we end today's lecture. Please do enjoy the rest of your evenings. Bye-bye.
Bye.